Good evening, everyone. Welcome back to My IVF Fences and our webinar tonight. It's great to see you all here, and I know that you will find this session interesting, and I know that you probably have lots and lots of questions. So don't worry, we do have a special expert with us tonight. This is Dr. Elias Tsakos, and I am very happy that you are back with us once again, Dr. Tsakos. How are you feeling tonight? I hope you had a probably busy day, but I hope you had a great day.
Yeah, thank you so much. Hi, good evening, everyone. I'm feeling full of energy despite the long hours. I'm still in my scrubs. It's 9 in the evening in Greece, and it's been a long day, but I'm looking forward to interacting with our audience tonight and sharing some information on how to get pregnant in advanced maternal age, which is the majority of our patients.
Of course, thank you so much indeed for coming back. Just let me remind everyone that Dr. Elias Tsakos, he's the medical director at EmbryoClinic, which is located in Thessaloniki, Greece. And so I'm glad that you have found some time to spend it tonight, and I'm sure that you will be able to help some of our patients. So just remember, tonight we will do it a bit differently. Dr. Tsakos will talk about, of course, how to get pregnant when you are in advanced maternal age. He will provide some cases as well, but without presentation, though. Of course, remember, you can type the questions even right now or later on, and Dr. Tsakos will definitely have time to answer them for you, so don't hesitate. And I guess now we can go ahead with the talk. Okay, and yeah, let's do it. Okay, let's go ahead.
Sure. Good evening again. It's been a pleasure joining these webinars, and it's a unique opportunity for me to share some of my experience and my team's experience that we acquired over the last 30 years in the field. And also, it's a huge opportunity to interact with patients all over the world. And I would like to congratulate the European Fertility Society for this initiative, because we do get feedback from our patients. We do get feedback from the practice in different countries, and we do learn a lot of valuable information. We have a lot of information from our patients through this interaction. So thank you for letting me be part of this. Now, advanced maternal age, 38 plus, this is the topic of my talk. And of course, there's a lot of success stories I could share with you. But before I did that, I would like to basically differentiate the means of success. There's two main types of IVF that we discuss with patients of advanced maternal age. One is the own eggs IVF, and the other is the egg donation IVF. And of course, maternal age is a huge factor of success in that age group. And this is, of course, even more important when we're talking about own eggs. Egg donation is there as an option. It has been an option for quite a few decades now. It's becoming more of use over the last maybe 10, 15 years. And as an option, of course, it is affected by the age, but not as importantly so as it is own eggs IVF. So I will talk about own eggs IVF first. As we all know, the quality and the quantity of oocytes in eggs is reduced with advanced age. And this reduction starts as early as in the mid-20s of the female. It becomes even more profound after the age of 30. After 35, it diminishes even more, and after 40, it diminishes to a great extent. As a result, unfortunately, the success rate of IVF has a lot of denominators, a lot of main factors, and maternal age, when we're using own eggs, is perhaps the most important factor. Regardless of what method we use, regardless of the stimulation protocol, regardless of the drugs we actually use and the methods in the lab and so forth, a female age of 38 plus by itself is an adverse factor for IVF success, and not only for IVF success, but also for pregnancy outcome in terms of either a miscarriage or complications of pregnancy. And of course, advanced female age is perhaps 38, but so is 40, so is 42, so is 45. So the huge question is, where do we draw the line? And the answer is, it depends. So I would like again to divide advanced female age females, those between 38 and 42 perhaps, and those from 43 to 46, and of course those from 47 to 50. As you know, in most countries, including Greece, the upper age limit for performing IVF treatment, female age limit is 50, used to be 50. In Greece now there's new law that has extended this limit to 52 in the light of the COVID pandemic, which prevented a lot of women from having IVF. So at the moment we run an age limit of 52 for the female under certain conditions, of course, and under a special license that is required. So between 50 and 52, we require a special license from the health authorities in order to perform IVF. So I will talk about own eggs IVF for 38 to 42. Again, for me, this is a very, very fine age group. I think we need to be very careful. We need to assess and evaluate as carefully as possible those patients. I don't think we can afford to waste a lot of time for these patients, and I think the patients also need to understand that time is precious. Perhaps 6 months or 8 months may make a big difference in with regards to the outcome, with regards to the quantity and the quality of their eggs. And for those patients, I think it's very important to ensure that we give them the best possible chance. This chance is based on their individual characteristics, so we need to evaluate their AMH, their ultrasound characteristics, their hormonal profile, their history, of course, some individual details in the particular case, and of course the male assessment is also important in order to provide them with the best possible option. So in this age group, of course, we always aim and pray for an adequate amount of eggs, an adequate amount of embryos that would give us the best possible chance. If I can give you some figures for someone at 38, 39, a couple in that age group, for the standard couple, we would be very happy to have 4 or 5 oocytes, and we would be very happy to produce 2 or 3 healthy embryos. And of course, how many we implant depends again on the quality of the embryos, on the wishes of the patients and the characteristics they have. So as an overview, we fight very hard for those women, for those couples with a female partner of 38 to 43. Now, invariably, some of those patients would have had already IVF cycles. They would have had perhaps failures in the past or even successes. So we even take into account, of course, the previous history, aiming at giving them the best possible chance. We use all the tools, all the proven tools of success in our stimulation protocols in terms of choosing the best suited protocol, trying not to overstimulate them, but trying to adequately stimulate them with FSH hormones, sometimes with the add-on of LH, and sometimes with the add-on of tablets in the likes of clomiphene and so forth. So I think as an overview, we're fairly optimistic for this age group, the age group of 38 to 42. Although modest success, the success is there. Roughly, we could hope and aim for success in the region of 25% in terms of pregnancy, and we would like to offer our patients that opportunity. Now, for the age group beyond that, 43 to 45, 46, of course, things are getting more complex. Our patients, they need to understand that success rate is very small, perhaps less than 10%, in some cases less than 5%, depending on the individual characteristics. And again, pregnancy complications are much higher, pregnancy loss, miscarriage, abnormalities, which would limit the take-home baby, the healthy take-home baby rate to very small numbers, perhaps in the region of 2 to 3%. Of course, many patients are not discouraged of that. I think it's only logical for the majority of the patients wishing to try with their own eggs in this age group, although they understand that the odds are against them. And some of the lucky ones, do succeed and do take home a healthy baby. Now, for the age group of over 46, 47, to my knowledge, there's only one report of a successful IVF pregnancy with a healthy birth in this age group, and our patients need to be aware of that. Again, sometimes it's very difficult to get to terms with this fact, and again, we get challenged by patients saying that, how will I know if I don't try, and all that. I think the scientific team, we have to be very realistic, but also we have to be psychologically very close to our patients and helping them understand their odds, and of course making sure that we minimize complications. Now, when it comes to egg donation, then of course the success rate is different. So maternal age is still important, both for the success of IVF and also for the outcome of pregnancy. However, with the use of younger genetic material, we can be more confident with regards to success. And of course, there we still need to evaluate our couples and our patients. We still need to be very careful in selecting our patients, selecting the treatment, selecting the program, selecting the protocol, if you like, ensuring that the patient's health is not going to be compromised. I insist on all my patients having formal breast assessment prior to IVF. We pick up perhaps half a dozen breast cancers in our patients at a very early stage, just before we embark on IVF. And I'm very confident that for those ladies, the prognosis is very good and their lives will be saved. I mean, recently we had an email from an international patient who thanked us for insisting on a mammogram which picked up a disease. So for all the age groups, but in particular for the advanced maternal age group, I think it's very important for us as physicians and for our teams and our patients to be aware that, first of all, we should do no harm. And first of all, we should ensure that our treatment is safe before it is successful. So I do insist on screening tests. I'm well aware that screening criteria in different countries differs on what is provided on the public health system. Sometimes they have to have private mammograms, for example, if the screening program doesn't include them, perhaps until they're 45 in some countries or 40 in some others. But I do insist that we don't cut corners in safety. So the advanced maternal age, we need to ensure that it's safe before they embark on IVF. So proper screening, health screening, female health screening, and also general screening for standard conditions like thyroid disease, heart disease, lung disease, sometimes depending on history and characteristics, and so forth. So safety is of paramount importance. So egg donation negates the adverse effect of genetic inadequacy, if you like, associated with advanced maternal age. However, it's not always successful. It's not always safe to perform. So we have to counsel our patients and be very careful in our pre-IVF phase, which is very important, even more important for the advanced maternal age patients. We need to ensure that we campaign for single embryo transfers for those patients, although we are under a lot of pressure to perform double embryo transfers in the egg donation cycles in order to maximize success and so forth. So there's a lot of understanding, a lot of counseling, a lot of discussions we need to have and we ought to have with our patients in order to build the trusted relationship that, in my opinion, is of paramount importance before we move on. I don't think there's an age limit scientifically. However, we need to obey to the guidelines and, of course, the legal scenarios in its country. So that is 50 years old for the female age, and we need to ensure that all our patients are screened adequately. We stick to this age limit. Of course, if there are exceptions, then under special conditions and following a special license from the authorities, we can still treat, I think, for a limited period of time because of COVID, patients up to the age of 52. Finally, I think we should not forget that apart from the effect on the oocyte quality associated with advanced maternal age, the uterus quality, the quality of the implantation environment, if you like, is altered with advanced maternal age. The chance of developing fibroids, polyps, or even cancer in the uterus is increased with maternal age. I think we should be very, very much aware of that. Only this year in my clinic, we had 2 cases of endometrial cancer picked up on the preliminary screening of patients just before they embarked on IVF. So safety, 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 and then success of IVF in an environment of understanding of science, but also of good rapport and good connection with our patients who need to understand that we're here to help. We're here to share our experience, and we're here to share all our knowledge in order to provide them not only with a healthy pregnancy, but also in a very safe environment and without compromising any safety issues. I think this is my overall lecture for tonight. I would like to be optimistic. I think 45 is the new 35, perhaps 50 is the new 40. With the advancement of technology and science, what was headline news perhaps 10 or 15 years ago now is common practice in most of the clinics in Europe and all over the world. I'm very familiar, of course, with the European units. There's some amazing hospitals, amazing units, and amazing teams. And I think we all work together. We should be working together in order to give our patients the best possible chance in a safe environment.
Wonderful. As always, brilliant. Thank you so much for talking about this and explaining. And of course, you are always inspiring. And as you can see, there are plenty of questions coming up right now. So yeah, let's go ahead. Let's have a look at the questions. As you can see, some of them are quite detailed. So let's get going with them. Okay, thank you so much. And let's have a look. So Christina has the first question. I'm 41, AMH was 3.59 picomoles last year in March. I have 2 frozen embryos at 40. However, since July this year, I have not had a proper period. It was just spotting. Is it possible for this to be perimenopause? My periods were fairly regular prior to this. What can I do, as I'd like to try to get more embryos before I am 42, before implantation? I am due to start long protocol, but not sure when due to lack of periods.
Okay, thank you, Christine. Well, to be honest, I wouldn't delay the embryo transfer very, very much for various reasons. So since you have 2 frozen embryos at 40, I can't really see why you're not implanting those, because your future child or children should be hidden in those storage compartments. So I'm not a big fan of accumulating embryos and before we do the transfer. To be honest, in my mind, I prefer to transfer the embryos as soon as they're ready. Prolonging this process perhaps is imposing you with unnecessary stress, unnecessary medication, unnecessary procedures, which are not always safe or stress-free. So my advice would possibly be to investigate why you're having this abnormality by means of a scan and some hormonal tests, and perhaps just get on and have a frozen embryo transfer before you have any more stimulations. And I hope you're not going to need any more stimulations. I hope you will be successful with those 2 babies you have in storage.
Thank you so much for your question, indeed, and your help with that. And as always, of course, there's a thank you from Christina for you, Dr. Tsakos, right here. Okay. Okay. Natalia has another question. Age 40-41, 4 IVF cycles, 8-10 eggs retrieved, 6-8 mature, 4-7 fertilized, and only 1 blastocyst of acceptable quality on day 5, 3 BB, 4 AA, morphology not testing. Is it possible way to know what follicle procedure that 1 blastocyst had? Maybe it's the leading follicle that would perform anyway, and the rest is just garbage in, garbage out, allowed to grow on excess FSH. Would it be sensible to change to mild IVF or even IUI in this specific case?
Sure. Okay, clearly I think it would be sensible to move on to mild IVF, perhaps not IUI. I mean, in IUI, at your age group, we would be looking at a very, very small single-figure success. And most importantly, we wouldn't know what went wrong if you didn't get pregnant. So yes, maybe mild IVF would be a way forward. Maybe some details in the lab would perhaps give you a little bit of better blastulation. Now, I don't think 6 or 8 mature oocytes is due to basically excessive FSH, really. Maybe there's a sperm factor associated somewhere there. So there's a lot of areas to be explored. Certainly, producing 6 or 8 mature eggs at your age is a very positive thing. So I would probably investigate the sperm a little bit more. I would probably look into the possibility of a mild IVF cycle, looking into the lab techniques. It's always optimistic if you're producing eggs, and I think I would be guarded but optimistic for the future. But it's not just the eggs; it could be the sperm. It could be other factors that affect your blastulation outcome.
And thank you so much for the clarification to this one as well. And Anna has another question. After failed transfers, would you recommend ERA test, ALICE, EMA, or are there better alternatives? How soon after ERA can you start taking meds for the next transfer?
To be honest, I don't use ERA test of any sort. I personally haven't been convinced by the evidence. Perhaps some other people have more experience. I have no experience at all with ERA test. I do not recommend it. I have never used it, so I really honestly don't know how to advise you on this. I think that monitoring a frozen embryo transfer or even a fresh embryo transfer with the standard methods at the moment, scanning, blood testing, ensuring that the endometrium is healthy, perhaps with a hysteroscopy, maybe with a biopsy. Or even with a panel of microbiology testing, in my opinion, and in our hands, is probably enough to ensure that we have a perfect or near perfect implantation environment, and also that the timing of implantation is near perfect.
Understood. Again, thank you so much indeed. And of course, there's a thank you from Anna and from our previous patient, Talia, for you here. Okay, John has 2 questions, so let me put those together here. How much time should a patient take after a failed transfer? I am 43 and I'm overweight, though I've lost 15 kilos already.
Sure. Well, again, there's no real science behind all of this, to be honest. Again, in my view, there's we have the body to recover and we have the soul to recover. So it depends on how one feels. I don't think we should be too pushy to do an embryo transfer. I don't think it's only the logistics of it. I think there's more issues associated with failure, a failed transfer, a next transfer, and all that. So overall, in my practice, I don't really tend to do back-to-back transfers. So I tend to suggest and leave perhaps a couple of months between transfers, just to ensure that everything has gone back to normal. Of course, we have ways to monitor that hormonically, ultrasonically, but again, it's also the psychological aspect. So again, there's no very solid science behind what I've said, but I think it's individualized depending on the patient and depending on the overall approach of the clinic. But I feel that perhaps a couple of months break is probably a reasonable time, minimum of 2 months.
All right. Again, thanks so much for yet another question and, of course, for your help and explanation. And Claire has another question. I had a natural pregnancy and birth at 42 using my own eggs. My daughter was born. We have been trying for years since, but no success. So have tried embryo transfer using donor eggs, 2 rounds without success. I've just had ERA. Do you think it's worth it? Just found out of 18 embryos, 3 suitable for PGS testing because of my husband's sperm. Think this is worth it?
Yeah, I mean, as I said before, I did say about the ERA test and my views. Now, yeah, PGS is. I think there is value of PGS in your case. In anyone over 40, there is value of PGS as long as you understand that PGS does not increase your chances of pregnancy. However, it helps you avoid an unnecessary transfer if all the embryos are abnormal, and even sometimes an unnecessary miscarriage. And so forth. However, it has its shortcomings. It is expensive. There is a little bit of debate as to whether, as to what we do with the mosaic embryos and so forth. So it's not as straight cut as we would have liked it to be. As I mentioned in my talk, I mean, you were in the lucky ones to have your daughter, and congratulations for that. As long as you produce healthy eggs and you're still of reasonable age, in my opinion, you can keep trying with your own eggs, with or without PGS.
Wonderful. Thank you so much indeed. Okay, I will go back to Joanne, the previous patient. Okay, she has says, thank you, Doc. This is very reassuring. Just FYI, it was a frozen cycle with embryos that were made when I was 37. We had 9 viable embryos remaining.
Okay, sure. I mean, 9 embryos is always a very good stock to work with, and I would be very optimistic that some of them would have healthy embryos and result to healthy children.
All right. Thanks again. And there's thank you from the patient right here. Okay, Amanda has another one. Just give me a second. It's right here. I am 40, have had 1 failed IVF cycle. It was an antagonist cycle with only 4 eggs retrieved, 3 fertilized, and only 1 reaching day 5 blastocyst. We had a frozen embryo transfer, but it was unsuccessful. Now we are considering moving to a flare procedure. Do you think the flare procedure is a good approach in these circumstances?
Difficult question. I mean, the flare protocol we've all used for decades, really. I mean, I personally use it for, over 20 years. I don't use it anymore. Doesn't mean that it's not successful. In my opinion, I think the most important factor in the number of eggs that you produce is the age. So perhaps there's no huge difference between various protocols that would be used. So if your doctors feel that a flare protocol would be suitable, I would go with that. Of course, the figures you're quoting are very standard figures for your age group. So, I mean, all I have to say is, to trust the feeling of the doctor. I mean, sometimes, the physician deciding on the stimulation protocol has a different feel once they've seen and examined you and seen how you responded to previous one. So, yeah, I wouldn't object to a flare protocol. And let's hope that will produce, I wouldn't wait huge differences in the outcome, in terms of measurable outcome, if you like, in terms of numbers and quality of eggs. But perhaps that might be more suitable for you, and that might produce you the beautiful embryo or embryos that we all wish for.
Okay, I just want to let you know that, of course, Amanda added, I meant to say my AMH level is 20, which I was told is too high for my age.
Sure, it is too high, but you may have, we have studied AMH quite thoroughly. We rely on it, but it's not always 100% accurate. So, it's always a good starting point. And of course, it may mean that you may have an element of polycystic ovaries, which again may mean that you may produce a bigger number of oocytes of perhaps less good quality. But I mean, it will be taken into account. And in general, we'd rather have a higher AMH than a lower one. At least we have the numbers to work with.
Okay, thank you again, of course. And let's have a look. Gina has another question. I'm 42, have had 2 failed IVFs, had 2 healthy blastocysts the first time, second time, but non-implanted. Could polyps interfere with implantation? Should we try again?
Yes, the answer is probably. Probably yes. Now, hysteroscopy has always been a valuable tool in investigating and diagnosing and ensuring that the endometrial cavity is clear. However, there are some papers showing that perhaps a small polyp doesn't make a huge difference in the implantation. But in general, to my mind, I would like a normal as an endometrial cavity as possible. So perhaps if there is a suspicion of the polyp on scan, it may be worth exploring further with a hysteroscopy. And also, please remember that generally the polyps we see on hysteroscopy are bigger than the ones we kind of visualize on the scans. And also, on the other hand, sometimes we find polyps on the hysteroscopy that have been missed on the scans. So in general, personally, in my experience, I'm quite a big fan of hysteroscopy because I feel that there's a lot of factors associated with the hysteroscopy that can improve the success, starting from simple things like a normal canal, cervical canal. So with a hysteroscopy, we ensure that we have a normal embryo transfer afterwards, because if we find a narrow canal, we fix it during the hysteroscopy, and also we ensure that the cavity is normal 100%. Sometimes we take a biopsy also, which ensures that the histology is normal. Sometimes, as I said, in advanced maternal age, we may find pathology which is even malignant, which can be of course a huge problem. So in general, I feel that in the workup of fertility patients, perhaps a hysteroscopy should have a valuable role, and more importantly for women of advanced maternal age, in which the chance of having an abnormal finding is higher, and certainly women with either implantation failures or miscarriages.
All right, again, excellent. Thank you so much. And actually, I remember there were at least few webinars on the topic when it comes to hysteroscopy. So of course, you can always go and check it out, okay? There are plenty of more information right there with Dr. Tsakos, obviously. Okay, let's have a look at the next question. So is AMH test the only way to check a woman's potential ability to produce eggs at an older age?
No, is the answer. No, AMH is one of the factors. Assessing the ovarian reserve is a fairly new factor. It's become popular in the last 10 years. My team and I will have been amongst the perhaps the first people who studied that, and we published our findings, which are now included in the European Society of Human Reproduction guidelines. And they show the value of AMH. AMH is an important factor of assessing ovarian reserve, and so is the antral follicle count, which we produce with the scan, the ultrasound scan. And of course, there's other ways to do this by the standard FSH measurement, the inhibin B measurement, and so forth. So no, it's not the absolute and only denominator of ovarian reserve, but it's certainly one of the most valuable ones. I think now in modern practice, most people use the AMH, including our team. We use the AMH and the antral follicle count.
All right. Again, thank you so much for the explanation. Okay, Anna has one more question. If I have a PGT tested euploid embryo, have done ERA and hysteroscopy, what are the chances of getting pregnant?
Okay, very tricky, difficult question. What's your age? What's your age group?
Yeah, Anna, if you can, 42. Mm-hmm.
Difficult. Perhaps less than 10%, I'm afraid, at 42. Maybe 10%, I don't know. It's very difficult. I haven't seen studies Depends again on what your uterus is like overall, depends on whether there's any associated factors. It's certainly a fair chance, but not as big as we would have liked it to be. Honestly, it's difficult to quote a figure. I mean, by the way, what have you been quoted by the clinic? And again, depends on the clinic as well.
All right. Thank you so much indeed.
What did the clinic quote?
Oh, okay. Sorry. It's right here. Less than 50%.
Yes. Yeah, but less than 50% is 40, 30, 15, and so forth.
Okay, sorry, but that was before ERA and hysteroscopy.
To be honest, Anna, I understand your stress, but yeah, as I said, it's very difficult because I don't think this has been evaluated, in general. But definitely, it's a very good sign having a euploid embryo at 42. But as we must understand, it's not just the genetics that influence success. There's so many more factors. But go for it, and you will find out for yourself.
Of course. Thank you. Indeed. 1 second. Okay, let's have a look. More questions are coming in. I'm 49. Probably will have to resort to donor eggs. How will the embryo be affected just by carrying it? Sorry. And also, I am in very good health, except I'm not sure here. Sorry. Type 3 hypermobility syndrome. Would you consider me?
Okay. To be honest, I'm not very familiar. I mean, I have to dig back into my undergraduate books. What could be the effect of your syndrome on pregnancy and pregnancy outcome and all that? So I would have to consult my physicians really before I can answer this. As you understand, we need to ensure that pregnancy and IVF and pregnancy will not compromise your condition, so I cannot answer that off the top of my head now. Now, yes, at 49, the logical way forward would be egg donation.
All right. Again, thank you so much, of course, for your advice here. And let me have a look. Do you believe that hysteroscopy increases the success rates with either with own eggs or donor eggs?
I do. We have done our own research and audit in my unit, and we found that it does. Actually, we presented some of our findings in the British Fertility Society conference a couple of years ago, that there was a small increase in the success. So overall, the answer is yes, I feel it does increase the success. There have been some scientific reports, and the mechanisms are the ones that I mentioned before. They can be as simple as from facilitating the embryo transfer, or removing pathology that hasn't been diagnosed before, or ensuring that the endometrium is healthy. There's a lot of factors that influence the outcome. So yes, I do believe that it increases. Of course, the question is when and who do we perform it to? Do we perform it on anyone before IVF? Do we use it selectively? Do we do the office hysteroscopy, in which we don't have the facility perhaps to do dilatation because it hurts a little bit? These are still remaining and unresolved issues, but overall I feel that hysteroscopy is a valuable tool in IVF.
All right. Again, thank you so much for explanation to this one as well. Okay, next question. If you use own eggs, but with a surrogate younger mother, are the chances higher for our age group?
Depends on your health. So, and depends on your age group. So, and depends on the difference. So, I can't really answer it straight away. So, I mean, for example, the surrogate carrier could be 40 and you could be 45. I mean, if you're healthy 45, I don't think it makes a huge difference between her and you. Of course, if the surrogate carrier is 25 and if you're an unhealthy 45 or 47-year-old, then it may make a bit of a difference. I don't think it's very easy to quantify the differences. Depends on the case, depends on the situation.
All right. Thank you so much indeed. Okay, and let me have a look. Natalia has added one more question. I am Hippo responder, 8 to 10 eggs retrieved while AMH is 24, 25 picomals. If it is genetic condition with FSH receptors not seeing FSH, can it be treated? How? Would love to have more eggs.
Well, to be honest, 8 to 10 eggs is not a bad score. How old are you, by the way? Natalie? 41. I mean, 8 to 10 eggs at 41 is fantastic. It's amazing. So I think, well, the standard, I mean, at 41, we were happy with 3 to 4 eggs. So you probably have double the number of eggs that we would expect for your age group. So yes, I mean, there's always a chance of FSH receptor issues and all that, but I don't think, in terms of outcome, I don't think that's a bad outcome. So 8 to 10 eggs at 41 is good going. It means that you have a good ovarian reserve. Probably you're very healthy, fit, and healthy young lady at 41. So that would give you a fairly good chance of pregnancy. Perhaps like the lady who spoke before, who wrote a question before, who got pregnant and delivered at 42. So you would be amongst the fortunate 41-year-olds.
All right, excellent. Of course, again, thank you so much for yet another question. And Natalie has added, okay, sorry, just give me a second, I will show it. And Natalie has added 1 blastocyst in 10 eggs, need more.
Yeah, well, again, it could be a sperm factor, could be I don't know, could be other factors like the lab factor, I don't know. Still, 1 blastocyst at 41 is good going. I mean, at 41, maybe 1/3. Well, put it this way: in my clinic, we don't accept all 41s. So for the program, if we feel that they wouldn't really have a good outcome, if they've had multiple failures, we don't accept them for own eggs IVF. If they've had multiple failures before, or if they have very low AMH or abnormal periods, or if they've produced 1 or no eggs, not embryos in the past, and so forth. So, I mean, from the ones we accept, we're lucky if we have an embryo transfer, because not all 41s, they produce embryos of good quality for transfer, and definitely having 1 blastocyst is a potential success. So I won't be discouraged by the number.
All right.
It could be that cycle. Maybe in another cycle, your 8 eggs or your 10 eggs might be of better quality, or the sperm might be better, or the interaction and the dialogue between sperm and egg is better. I mean, at 41, if someone is producing blastocysts, they could potentially be successful. So I would like to be optimistic.
Of course, as always, right? Thank you so much indeed. And Natalia, I see. Thank you very much. Okay, there are like 3 questions left. We will be slowly finishing. And now there is a question about supplements. There are 2 questions about this. So what is your opinion on supplements, DHEA in particular?
Yeah. Yes, I do have an opinion. There is some evidence that there are some papers indicating that DHEA may be helpful in a subgroup of patients. And also DHEA has no really major side effects. It's inexpensive, widely available. So I use it. I mean, I do use it for my patients, either the ones that have not responded properly in previous stimulations, or the ones of advanced stage of over 40 perhaps, prior to the IVF cycle. I think it does no harm, and it may benefit a small group of patients. Our problem at the moment is that we can't identify which group that is, so we may be giving it unnecessarily to the others. But as I said before, it's inexpensive, widely available, no serious side effects. We only give it for perhaps couple of months, 6 weeks to 2 months prior to IVF. So I think there's no harm giving it. We do not expect miracles. I mean, we don't expect a 42-year-old to produce 5 blastocysts with this. However, it may make a small difference and give us an opportunity to provide you with a healthy embryo and a healthy pregnancy.
Okay, perfect. And just one more. So is there anything else that you can do to improve the quality of the eggs?
Yeah, sure. I mean, lifestyle helps. Make sure, however, you don't lose a lot of weight all in one, because that may have an adverse effect. But I mean, general healthy lifestyle, and I'm not referring just to the body, but also to the soul. So positive attitude, healthy lifestyle, a bit of extra time for meditation, for acupuncture, for anything that could pamper your body and soul, perhaps will help. And if it doesn't help in a quantifiable manner, it will definitely help your experience. Will definitely help you go through IVF with less stress and with more positive attitude.
Exactly. Thank you so much indeed. Okay, now Anna, possibly that is our final question for tonight. If you have anything left, just go ahead, type those in. And there's a question: would you suggest anything else to improve the chances for the next frozen embryo transfer except hysteroscopy after failed attempts, 0 HCG of euploid embryos?
Well, very difficult. I mean, there's a lot of steps that could influence the outcome. You know, from the endometrial preparation, whether you would use tablets or whether you would use down regulation or not. Some people do, some people don't. Whether you would use a standard or a higher dose of estrogen and progesterone. The timing of the embryo transfer is also important. The timing of progesterone and the dosage of progesterone. And of course, the lab plays a huge factor for the outcome, whether how the protocol they use to thaw, whether they do assisted hatching or not on thawed embryos. This is something to be discussed. And of course, the embryo transfer itself, the technique, how it's done, when it's done, is it done by perhaps a more senior person in the unit and so forth? Are they happy with the scanning images they're getting? Is it under ultrasound guidance or not? So there's a lot of factors that could influence frozen embryo transfer and IVF itself. And I mean, that's why we value our team so much, because if one of us doesn't do things optimally, then perhaps the outcome is influenced, even if everything else is done perfectly. And of course, your overall approach. I mean, to try to be physically and emotionally as relaxed as possible and as positive as possible. I mean, I always say that once you've decided to follow a clinic or a doctor, just trust them and let them do what's best for you. If you don't trust them, just change them. I think there's no third way around all of this. Let the people who care for you do the very best to help you.
Amazing. Again, thank you so much. And there are like two more very short ones. Okay, so let's get ahead with them. Any other supplements in addition to the HEA?
Yes, there are some multivits that they contain some oxidants and so forth. There is a little bit of research behind them. So, there's lots of commercially available multivitamins for use just prior to conception. But I mean, DHEA is clearly the one associated with the potential increase of response to stimulation. So that's why this is perhaps one of the most important supplements.
All right. Thank you for the clarification. And one more. Do you have any views on whether it's worthwhile having endometrial scratch or embryo glue?
Embryo glue, again, there is some evidence, although it has been challenged. We use it. We invariably use it. I'm not sure. I'm not really convinced of its efficacy. However, we use it. Now, endometrial scratch, there was some evidence to promote that. However, now it is a little bit disputed. I don't think it would make a huge harm to use it, to be honest, although the Human Fertilization Authority is a bit cautious now towards those add-ons.
All right. Again, thank you for the clarification to this one as well. And of course, Amanda would like to thank you. And okay, one more, just very short one. So, do you think it's okay to use FFP2 face masks when pregnant?
I don't know is the answer. I really don't know. I mean, definitely FFP2 is protective. I haven't seen any research on whether it affects pregnancy in any way, so I'm sorry I couldn't answer that.
Okay. Sorry, one more last one that Joanne said. So sorry, just let me go to this one. What vitamins would you recommend just before implantation?
Sure, definitely folic acid. And probably vitamin D, depending on where you live and your lifestyle and all that. So definitely folic acid and probably vitamin D.
All right.
And of course, I like to ensure that, the general sort of full blood count is normal and ferritin levels are normal, because some women do have a little bit of heavy bleeding. I don't want them to start a pregnancy if they're anemic or if they're low on iron. So it may be worth measuring your iron and ferritin levels and the full blood count to ensure that at least your standard blood component is normal.
And for
How long can you take folic acid? Well, for as long as you're trying to get pregnant, at 0.4 milligrams per day. And at a higher dose if you have a history of spina bifida or any folic acid deficiency associated disease.
All right, excellent. Okay, one last question, okay? This time for sure. Is a HCG infusion before transfer beneficial for a frozen embryo transfer?
Would probably not is the answer.
Okay,
Probably
understood.
Not. Yeah, there's no solid evidence behind it.
That makes perfect sense then, of course. So, yes, I believe that was our final question. But of course, as always, remember that if you would like to get some more details from Dr. Tsakos and his team at EmbryoClinic, I'm sure they will be happy to help you. You will be redirected to the website after we finish. So all you need to do is just use the contact button and all the questions will be forwarded right there. Dr. Tsakos, it's always amazing to have you here. And I'm very glad that we get to cooperate every now and then. And of course, there are some more webinars coming up in October. So stay tuned. You can already sign up for the webinar with Dr. Tsakos on the 12th of October, if I remember correctly. So I'm already looking forward to this. And well, thank you everyone for joining us. Dr. Tsakos, there are plenty of thank yous and comments for you. So as you can see, it's been very, very useful. Is there anything else you would like to add before we?
No, I would like to thank you once again for the invitation. I would like to thank the amazing audience for the stimulating questions. Sorry I couldn't answer all of them. I hope I have been helpful to some of you. And I would like to wish you all the very best. Don't give up. Don't give up. Keep going. Keep reading. Keep watching webinars. Keep getting information. And keep challenging us, because through this challenge we learn a lot. Thank you so much for this challenge tonight. It's been amazing, and I hope to see you all very soon online.
Yes, we will be back very, very soon. So thanks a lot, everyone. It's always amazing to see so many questions, so many comments, and I know that it's been helpful, and some of you already contacted the clinic. So that means that everything is working and everyone wants to get some answers, and it's happening as well. So I'm very happy about this as well. Thank you so much. Have a lovely week. Not yet, weekend, almost weekend. So I do believe that it's been useful for you. And of course, we will be back next week on Wednesday. So stay tuned and see you soon, of course. Thanks so much. Take care.
Take care. Good evening. Bye-bye.
Bye-bye.
Bye.